result was in the last 3-4 days?
As I start, I will be just quoting Dr. Sheff, who is a very senior radiologist, myocardium. But the cardiac MRI is moving beyond imaging of the myocardium, and the CT is moving beyond imaging of the coronaries. And this is a very interesting case example soon. And these images, you'll be surprised, are from an MRI machine and MRI. And these are the conventional CT images. I think you're all comfortable looking at it. Things a lot of interesting. So the next 6 minutes, we'll just quickly look at what's happening in CT and MRI. We know the problems with the existing stress tests. So we were looking at new techniques to help us in the screening of a large number of patients. American College of Cardiology and the SCCT got together and did a writing group, and they've got a lot of these syndromes where it was either inappropriate, appropriate, or uncertain whether to use cardiac CT, and there are a whole number of them. You can refer to this document. It's as late as 2009. We're yet to have a 2012 where we have found that there is a huge lack of correlation between the Framingham risk on one side. So that's a very good thing that we're going to have a lot of projects in the pipeline. The SCCT is the current performance and for the interpretation and for the reporting. So it's very, very important when we are starting a cardiac CT program. These are the guidelines which have to be followed to ensure that there is uniformity and accuracy in the reporting. The basic requirements of cardiac imaging are obviously high temporal resolution. We have surmounted that by a fast gantry rotation of about 0.3 seconds rotation, high spatial resolution by very thin collimators, and a fast continuous coverage by multi-slice by ECG gating. This is an example, a workhorse machine which most of us are comfortable with, single source CT, a fairly good temporal resolution of 165 milliseconds. You need to just do a 180-degree rotation. The computer takes care of the rest. Very temporal resolution, and the data with 16 and 64 is fairly good with almost available segments. But CT is moving on from 64 slice, and there are two groups which, let's see what they did. 4, 16, 64, that's where we came. And then suddenly there was this big jump. It was very, very interesting. The Aquiline 1 was released by Toshiba. And you can see here that especially in the pediatric group patients and very, very large patients come down with decreased radiation. The biggest advantage here is with a large volume, you're able to cover the whole heart in a single heartbeat, and therefore all the artifacts which people were really sort of commenting on really sort of got reduced, and also the radiation dose came down because it's a single heartbeat image. Now the German group led by Siemens went in a different direction, and they said we would look at only 64 slice, but we would look at two sources. And these are the two sources you can see. And two sources and two detector arrays of 64 each, giving a combined 128 slice. And the temperature is excellent. And you can see because of slip ring technology, you're able to move this huge gantry. So the dual source led by the Germans, that is a somatome definition machine, really revolutionized imaging. We are happy to be one of the first people using it here. And the biggest advantage was that even at a high heart rate, and we know that most of our patients, they come to our outpatients, they're on beta blockers, still the heart rates are between 80 and 90. Put them in a scanner, and I see a lot of them every day, it just shoots up to 110. And the dual source just does the job very, very easily. And you can see some. So the clinical benefits was with almost minimal beta blocker, you could go ahead and do these scans. Patients with arrhythmia, we have the minimal physician association really cuts down the time and the money when you're doing these scans. The Germans, so you had 256 slice with the dual source, and that made the temporalization even better, 25 milliseconds, and the data from there is almost excellent. And what we are seeing, in fact, the last SCCT conference that I went to, the radiation because of lack of time, and I just wanted to show you an update. We know about radiation. There's radiation. Changes in the developed world, obviously their myocardial perfusion scans were the first step before you would go ahead. India, it was the coronary angiograms, but now CT. We are also looking at CT in various other groups of disease, in fact, patient with stable CAD. The MEDIC trial looked at CTA versus CAG. This was all dual source machines across positive predictive value. And this was a whole consortium of 320 slice scanners across the world, international trial. So cardiac CT is really getting there as far as perfusion goes, and we're also looking at scar imaging guidelines. Trial was an important trial where we were looking at radiation scores, and a few things like scan range, ECG pulsing software was reducing the the ROMICAT study looked at the CTA in the emergency room, and I just want to make a mention of FFR by CT. We're going to be showing this in the August meeting. So this is something that you need to watch this space in August when we are presenting it. Just a short word on dual energy, and you will just look that the dual energies, dual source scanners can also look at dual energy. And you can see that that area has decreased lung flow. I'm going to stop here. Respect to time. This is our pediatric for your patient listening. Thank you very much.